Good afternoon, everybody. I've just been virtually transported from the other side of the conference center and just in time to welcome you in name of the European Board to the scientific session of our ECoPEaT meeting. Before we start with the scientific session, I will give Gertie de Beukelaar, our General Secretary, the opportunity to properly welcome you to this meeting.
Good afternoon, ladies and gentlemen. Welcome to the 20th edition of our ECoPEaT meeting. As you noticed, we had to change the concept of our meeting. We are no longer physically present in Barcelona, but we are happy to meet you virtually on this new platform. This platform is accessible for free for perfusionists from all over the world, so we will for sure have a great audience today. This is an anniversary edition of our meeting, so we have chosen as the theme celebrating milestones and remembering benchmarks. I hope you have enough access to scientific activities nowadays, but for today we have managed to put together a very interesting program. It's an honor for me to announce the first speaker, and that is Dr. Stefan Boucher from the University Hospital in Ghent in Belgium. He's cardiac anesthesiologist and can be regarded as a monument in the field when it comes to cardiac perioperative ultrasound. So I would say sit back and relax and enjoy the next 90 minutes ride.
Before we go over to this first talk, which was already nicely introduced by Gertie, I just want to say this session will be divided into two parts. We first have 3 invited talks, and they will be focusing on the evolving role of the perfusionists. After those 3 talks, which are pre-recorded, you will have the opportunity to ask questions because there will be a live question and answering. After the question and answering of the first 3 talks, we move on to the abstract session, in which we will focus on the abstracts which we received and which were accepted for oral presentations. The abstracts which were accepted for poster presentations, you can look at in our booth. So I will give the word now to Dr. Boucher. He's introduced already. Thank you.
Dear friends and colleagues, it's a great pleasure and a privilege to talk about the benefits of echocardiography for the clinical practice of perfusion. Unfortunately, I don't have any disclosures, and this lecture is mainly based on a recent review article published in the Journal of Perfusion. Remarkably, 2 landmarks in the history of cardiac surgery share the same year of birth, 1953. The first successful use of cardiopulmonary bypass by Gibbon, and the introduction of echocardiography by these 2 gentlemen, Adler and Hertz. Both technologies have evolved since then and joined hands in the modern practice of cardiac surgery. The perioperative T exam focuses not only on the cardiac anatomy, but has in fact different roles as the different phases of cardiac surgery have different requirements. During surgery, T is used by the cardiac anesthesiologist as a complementary hemodynamic monitor, but also can have a rescue role or can be used as a procedure adjunct. Therefore, I've outlined a stepwise approach to define the role of TE during cardiac procedures, starting from the confirmation of surgical diagnosis over procedure guidance, and at the end even the verification of the success of a procedure. From the perspective of a perfusionist, we could focus on the role of TE during 3 stages of the cardiac procedure: pre-CPB, during CPB, and at the end of CPB. Now, before the start of CPB, TE is able to detect or diagnose pathologies that may affect the implementation and the course of CPB, like, for example, the presence of aortic atheromata or a new diagnosed aortic rehabilitation, and it may also serve as an adjunct in the correct positioning of cannulas before the initiation of bypass. Now, regarding aortic atheromata, stroke remains one of the biggest risks faced by patients undergoing CPB. in cardiac surgery, the risk of stroke is approximately 2%, but when high-grade lesions in the ascending aorta are present, this number significantly increases up to more than 15%. Now, emboli to the brain most likely occur when the ascending aorta is manipulated during cannulation or during clamping. Another important cause of stroke is the sandblasting effect caused by high velocity of blood flow at the outlet of the aortic cannula. A 5-grade scale is used to indicate severity of atherosclerosis, which is correlated to the incidence of stroke during cardiac surgery. Grade 1 is considered a normal aortic wall, while a grade 5 indicates the presence of mobile lesions. Grade 5 carries the highest risk for stroke, so if detected, this may warrant modification of the surgical technique or site for cannulation. One disadvantage of TE is that the distal part of the ascending aorta cannot be visualized properly because of tracheal interposition. This is called the blind spot of TE. Next to aortic atherosclerosis, the presence of aortic regurgitation has important implications for the course of surgery and the practice of perfusion. As shown here on this pressure volume loop of the left ventricle, significant aortic regurgitation may lead to distension of the left ventricle and also induces an increase in stroke volume. All these things together, all these changes, lead to an increase in myocardial oxygen consumption. So in these cases, an LV venting catheter and or an aortic clamp should be placed without delay once on CPB. Now, as you all know, aortic regurgitation may also affect the delivery of antegrade cardioplegia, so both surgeon and perfusionist should plan how to optimize myocardial protection during surgery before the onset of CPB. The evaluation of LV size and function is common practice in cardiac surgery nowadays, but it's also worth considering by the perfusionist as well, as this is related to CPB blood volume. The blood level in the venous reservoir will rise much more in a patient with a severe dilated poor functioning left ventricle compared to the blood volume of a patient with a small, good ejecting hypertrophic heart. Also, TE provides excellent visualization of the great vessels, and this may facilitate the correct placement of cannulas and catheters during surgery. I just want to share with you some examples which I won't discuss for the interest of time. Now, concerning minimally invasive procedures using peripheral CPB and femoral access, there are numerous changes in hemodynamics, including a decrease in left ventricular preload and, of course, a dramatic increase in left ventricular afterload. At the onset of CPB, the heart continues to eject while the pump flow is gradually increased by the perfusionist. This may lead to a competitive flow between the ejection of the native heart and the retrograde pump flow. The incomplete mixing of blood and the priming solution often creates a pseudo-dissection image in the descending aorta, which is shown here on the right upper echocardiographic image. Below this image, a true dissection is shown. This dissection will create an intimal flap, which creates a false and a true lumen and is associated with very high pressures on arterial pressures on CPB. During open heart procedures, air is introduced, of course, in the heart cavities, and this may lead to coronary or cerebral embolization when the heart starts to eject again. Macroscopic air should be removed from the heart before weaning and certainly before decannulation. The residual air often embolizes to the right coronary artery, leading to a deterioration of right ventricular function, which may require a return to bypass in some cases. The main goal of weaning from CPB is a smooth transition from mechanical circulatory flow to spontaneous systemic circulation. If the function is adequate at the end of CPB, the perfusionist should continue weaning until the desired preload is achieved, shown here from the upper left to the right lower echocardiographic image. An increase in LV preload is associated with an increase in end diastolic volume or area on TEE. A small end diastolic area or volume together with kissing papillary muscles or walls indicates poor preload and is shown in this upper left image of this slide. Good left ventricular preload is achieved after reinfusion of blood and is shown on the right lower image on this slide. Now, when the size of the left ventricle remains poor, despite adequate reinfusion of blood volume, blood loss in surgical field should be considered. Sometimes also it's difficult to wean a patient from CPB, meaning that despite the initial reinfusion of blood, hemodynamics remain poor. So a comprehensive echocardiographic assessment of the left and the right ventricular function could help to cope with this difficult situation. Now, difficult weaning may suggest poor left ventricular function with or without regional wall motion abnormalities. Now, new regional wall motion abnormalities suggest a coronary bypass problem, and this should be checked by the surgeon before further weaning of bypass. Poor global contractility, despite adequate preload on TE, is an indication for the administration of inotropic support. Now, patients with left ventricular hypertrophy suffer from diastolic dysfunction, meaning that despite adequate systolic function, these ventricles have a filling problem. So these ventricles need more than normal atrial filling pressure to fill the heart adequately. Also, the ventricular wall is much thicker, so it's necessary to maintain or even increase coronary perfusion pressure before the start of the weaning process. Occasionally, weaning doesn't go smooth even while the left ventricle is contracting well. The presence of SAM, or systolic anterior motion of the mitral valve, may lead to this poor circulatory flow and poor hemodynamics. When diagnosed on TE during weaning, the perfusionist should increase preload even further and maintain and even increase mean arterial blood pressure. If inotropic support is being administered, this should be stopped in an attempt to reverse this dynamic problem. Here is just a summary of these different problematic scenarios and the measures that could be taken by the perfusionist. I need to mention that this is a personal recommendation and this may vary somewhat depending on institutional habits and guidelines. After successful weaning and removal of the venous cannula, protamine administration is started. Now, pulmonary hypertension is the most severe complication associated with its administration and occurs in almost 1 to 2% of patients. Pulmonary hypertension may lead to right ventricular dysfunction and hemodynamic collapse, which may require immediate reinstitution of CPB. Therefore, it's common practice to leave the aortic cannula in place when protamine is being administered. To conclude, TE, transesophageal echocardiographic assessment, may also serve the perfusionist within the surgical team by providing image guidance to help the management during the different stages of CPB. So the understanding and interpretation of the information provided by TE is definitely useful to optimize clinical perfusion practice of the modern perfusionist and should be considered part of the perfusionist curriculum. Well, thank you for your attention.
Thank you, Dr. Boucher. This was a very valuable talk, and I'll see you in a few minutes in live. I'm sure there'll be questions for you. For our next talk, we thought it would be interesting to chat about normothermic regional perfusion for organ donation. It's a new area, it's very promising, it's very exciting. And we invited Carlien de Gezelle. She is the head perfusionist of the University Hospital of Leuven. And together with her team, they did a tremendous job in getting this program started. I'm sure you will be very excited to hear all about it. Carlien, please, it's yours.
First of all, I would like to thank the organization for giving me the opportunity to present during the ECoPEaT meeting. The topic of this talk will be the evolving role of the modern perfusionist, normothermic regional perfusion for organ donation. I have no actual or potential conflict of interest in relation with this presentation. One of the greatest challenges in organ donation remains the shortage of suitable organs. The number of patients on the waiting list remains high, and the number of days on the waiting list in our heart center is increasing, while there seems to be a certain plateau reached in the number of heart transplantation. And this is the case in Belgium, but also in the rest of Europe. To resolve this organ shortage, we have been pushing the limits by accepting higher risk grafts, and therefore we have regained interest in DCD donors. DCD donors are donors where death is determined based on cardiac circulatory criteria, in contrast with the DBD donors we all know, where death is determined based on neurological criteria. Grafts from these DCD donors are subjected to a defined or undefined period of warm ischemia, and this will cause the injury to the organs. There is a classification in DCD donors, and the type of DCD donors which are the most interesting to expand the donor pool are the donors in category 3. We all know these donors because these donors are submitted to the ICU, mostly with a devastating brain injury, but not fulfilling the criteria of brain death, and where further therapeutic treatment is futile and the decision is made to stop the therapy. This is a classical DCD3 timeline. So first you have the withdrawal of life support, which is followed by a period of hypotension and hypoxia during the agonal phase until the circulation is ceased. After the circulatory arrest, there is a mandatory period of no touch before death can be declared and the procurement can take place. This defined no touch period is used to ensure that autoresuscitation cannot take place. The time between the withdrawal of life support and the declaration of death will determine the duration of the warm ischemia. The effects of warm ischemia to the organs will further exacerbate during the later period of cold storage and transportation. Normothermic regional perfusion may restore the cellular energy substrates and improve organ quality of ischemically damaged organs. And secondly, normothermic regional perfusion may provide us the ability to assess organ function before transplantation, and therefore this may lead to superior outcomes. So how does it work? Well, during NRP, an arterial and venous cannula are placed and circulation is restarted using an ECMO circuit. It is of utmost importance that there is a clear distinction between ECLS and NRP. While ECLS is a therapeutic option for a living patient who needs critical care, NRP is an organ preservation strategy in a donor to resuscitate the organs. Depending on where you clamp the arteries, you define a certain region you are aiming to perfuse. Regional perfusion of the abdominal organs is called abdominal NRP, and regional perfusion of not only the abdominal organs but also the thoracic organs is called TA, or thoraco-abdominal NRP. After abdominal NRP was applied in the mid-80s in Spain, it soon became a well-established technique to preserve abdominal organs, after DCD donation. And at that moment, the abdominal NRP was mainly performed by donor coordinators, ICU staff, or the so-called organ perfusionists. Since 2017, when a team of Pepworth published their results of successful DCD3 heart transplantation after TA NRP, a lot of cardiac surgeons and also perfusionists gained interest in this technique. And soon TA NRP was spread out over the rest of the UK and also in certain countries in Europe. Although as a perfusionist, NRP seems a pretty simple technique to resuscitate donor organs, there are some ethical and legal considerations to make before starting an NRP program. And these concerns are pretty important for the failure or success of these kind of programs. And therefore, a perfusionist must be aware of these considerations. There is something which is called the dead donor rule, and this is the ethical code which says that you do not kill patients for organ donation, and organ retrieval cannot cause death. Ante-mortem interventions may contribute to the death of a patient, and therefore it is not allowed in some countries. In our center, it is allowed to give ante-mortem substances like heparin to prevent thrombosis, but in our center we are not allowed to cannulate before the withdrawal of life support therapy. What is allowed in our center is that we can place guide wires before a therapy is stopped, and this facilitates us to fastly cannulate the artery and vein to start the NRP. The dead donor rule also states that a donor must be dead before you can retrieve his organs. And because the definition of death is different from country to country, not every country is able to procure organs from DCD donors. As you can see on the map, 18 countries, which are displayed in green, can have a DCD program. And because of the same reason, the no-touch period before death can be declared differs from country to country. In most countries, the no-touch period is set on 5 minutes, but there are also countries where it is 20 minutes, like in Italy, or even 30 minutes in Russia. And these periods will prolong the warm ischemia time and also the damage to these organs. Thirdly, once there is the circulation has ceased and the death has been declared, the loss of circulation must be permanent, and therefore you may not restore the recirculation to the brain. And to prevent the perfusion of the brain, we will have to clamp the supra-aortic arteries. To know if it's feasible of clamping all the aortic vessels, you can perform CT angio. And you might have aberrant circulation, especially the subclavian and vertebral arteries might have an aberrant origin on the aortic arch, and therefore it can be difficult to clamp all the supra-aortic arteries. And even although all these measurements are taken, collateral circulation to the brain may theoretically still occur through a variety of connections between the intercostal arteries and the spinal arteries. And this potential collateral flow to the brain needs to be diverted away from the brain. This can be established by selective cannulation of the arch arteries, which can then be drained into a reservoir. And finally, I would like to share with you our first experience in DCD heart transplantation after TA-NRP. As you can see, two donors came from a different center, which was the center in Liège, which is also the center who performed the first DCD heart transplant in our country, and two donors were from our own center. The time from withdrawal of life-supporting therapy until NRP is started ranges between 15 minutes and 30 minutes. And the total NRP support was between 6 minutes and 108 minutes. All our recipients received retrograde cardioplegia, and the cross-clamp at the donor until the time that the clamp is released at the recipient was of course longer with the donors which the hearts which were procured in the center in Liège. The reperfusion time of the heart after the cross clamp was released until the patients were weaned from CPB was around 30 to 40 minutes, and there was no patient who needed mechanical circulatory support. The cardiac index 7 days post-transplant was between 2 and 3.2 liters per minute per square meters, and the ejection fraction 7 days post-transplant was between 45 and 6. Days on ICU were between 4 and 8 days, and the total hospital stay was between 11 and 36 days. Also, the most recent cardiac index is okay, so between 2 and 3.9, and this is the same for the left ventricular ejection fraction. To conclude, I would like to say that new organ preservation techniques and protocols have entered the clinical arena. And it seems that DCD heart transplantation programs using TA-NRP is feasible and safe. There is a need for dedicated, experienced healthcare professionals, and a new working area is offered to the clinical perfusionists. And it's my personal opinion that it's up to the perfusion community to take on this challenge. Thank you.
Thank you, Caroline. That was a very nice and interesting presentation. I look forward to see you live for the questions and answers. The third invited speaker, the third topic that we thought was interesting for the modern perfusionist was an update on data registration and the influence on the quality improvement in perfusion. And to bring this topic, we went all the way to Australia, knocked on the door of Rob Baker, who's really recognized in this field. And we'll see him now for the pre-recorded talk, and hopefully we can teletransport him from his bar in Adelaide for the question and answer session. Rob Baker, it's all yours now.
Thank you for the opportunity for presenting at today's symposium. I'd like to especially thank the European Board of Cardiovascular Perfusion Congress Organising Committee and EACS for supporting this virtual meeting that we've all been able to attend over the last 2 or 3 days. I guess at no time in certainly my living memory has it seemed so far between Australia and particularly Adelaide, where I live, over here to Europe, where many of you are listening to this presentation. This is a photo of my hospital. This is Flinders Medical Centre. It's fortunate in that it's on a co-located campus with Flinders University, which makes it an excellent institution to work in. I've entitled this slide Now More Than Ever, and it's because I want to explore 2 themes in relation to data and to quality, and look at them in a number of different ways in the 10 or 12 minutes that we've got to share with each other today. Now, how do we go about informing practice? How do we change or understand or measure or do what we want to do? Well, we get our ideas and we get our protocols and our standards from textbooks, from guidelines, journal articles, from various sources. And we try and utilise all these sources to come up with our best practices. And in this modern era, where data is now very accessible, we're able to do some of this in real time. So I guess we've seen a change in time with respect to, timeliness. It's a lot, what we do and what we're able to see is much more readily available to us than it ever has been in the past. I want to leverage the European guidelines just a little bit in this presentation, and particularly in relation to training, education and service delivery, the last 2 on this slide. That is that it's recommended that perfusion departments be structured around a quality management framework, and that each perfusion department has specific standards and operating procedures for all aspects of the conduct of cardiopulmonary bypass. And also these in relation to data collection, data quality and quality improvement. In the data recording, quality assurance and quality improvement are really important. And it's really very, very good that the guidelines have given such prominence to these aspects of what we do. I think most people would feel as though they've got a fairly good handle on quality assurance and quality improvement. But I thought this paper for the British Medical Journal in 2019, last year, really, to me, just sort of reinforced some of the important points, and I wanted to share them with you. So what you need to know, well, participation in quality improvement can help us improve care together and develop important professional skills. Effective quality improvement relies on working as a team and using a structured methodology. And you need enthusiasm, perseverance, some skills and a willingness to share your project such that you can seek support from other people. So how did the authors define quality improvement? Well, quality improvement aims to make a difference to patients by improving safety, effectiveness and experience of care, by understanding our environment, by applying a systematic approach, and designing, testing and implementing changes using real-time data. So I think these are things that we can all readily aspire to. So what skills are needed? Well, enthusiasm, optimism, curiosity and perseverance are critical in getting this started. You need to be able to relate to other people, and you need to recognise that quality improvement is a team activity. You can't do this in isolation. No one person can bring the skill set to the table that can answer all of the aspects for a successful quality improvement project. And if you think about cardiac surgery as a whole, we work in a team. It's important that we do quality improvement in a team as well. What approach? It doesn't matter. No single approach is best. You get your PDSA cycle, you do your work, but most importantly, take the time to look at the output, look at the data, look at your results, and really drill down, dig deep into what the information is showing you. Now, if we look at data in registry, Perfusion is in a wonderful situation. We have a number of commercially available data management systems that we can use during cardiopulmonary bypass. There's a number of different registries that are available to us that we can also participate in, be them perfusion registries, cardiac surgical registries, or something like the also ECMO registry. They are all there to help us as we go forward. Now, this is a picture of a silo actually located between Adelaide and Melbourne. It's a journey of about 1,000 miles and 1,000 kilometres, and this is about 300 kilometres down the road from Adelaide. And the local community commissioned this artwork on the silos. When we talk about silos in medicine, we often talk about the silos between different groups of practitioners, between surgeons and perfusionists, surgeons and anaesthetists and perfusionists. But what I want to talk about is looking at silos in terms of how we look at the information that we collect. We look at our heart-lung machines. We look at different databases. Our Australian and New Zealand Collaborative Perfusion Registry is able to harness the electronic data from our heart-lung machines, but a lot of the other data registries can't actually interact with that at that first level. We can also interact with our local hospital systems, and how we develop those interactions is going to be incredibly important as we move forward, because in getting this interaction between all the different data sources that are available to us is going to help us improve the practice of perfusion for our patients. I'm very lucky to be involved in a project called Focus 360, which is about phenotyping clinical outcomes for patients. And it's about using all of the different data sources that are available there, all the different electronic data sources within our state, to try and improve clinical processes and outcomes. Now, I just want to remind you, data and quality is incredibly important to us. Now, this publication came out in August 2020, so just a couple of months ago, and it was entitled The User Guide for the Review of Clinical Variation in Healthcare. And there are similar publications in the European Union in the various countries, but this is just one that relates for me. And why I thought it was important was it really sort of spells out some of the foundations that I truly believe in terms of what we do. We need to monitor variation in practice against health outcomes. We need to provide feedback to clinicians such that they know what they're doing. We need to review our performance against external measures. This is what we call benchmarking. We need to support us as individuals to review our clinical practice. We need to use that information to inform improvement. And we need to acknowledge when things haven't gone quite right. So what is appropriate care in our setting? This definition of appropriate care means that patients are receiving the right care and the right amount of care according to their needs and preferences at the right time. The care should be offered on the best available evidence. And clearly that's what we'd like to do as perfusionists in our space. And, and what is clinical variation? Clinical variation is a difference in healthcare processes or outcomes compared to our peers. So it's us measuring ourselves against other people. And it's us being able to determine whether we're practicing in an appropriate or inappropriate manner. And that comes to measuring or reporting unwanted variation so we can improve our ability to meet the patient's needs, so we can ensure that we're doing the right thing. If clinical variation doesn't reflect a difference in patients' clinical needs or preferences, then it's unwarranted and it can give us an opportunity to improve. So the challenges for us as a perfusion profession are what is appropriate care and what is clinical variation. I just want to look at this from the lens of the Australian and New Zealand Collaborative Perfusion Registry just a little bit, using some of the recommendations from the European guidelines, specifically looking at a quality management framework, quality assurance and improvement. And we can see that as a quality assurance measure, what we do is we report quality indicators in our annual reports. So this multi-centre, this is actually the executive report, but in our reports we're able to compare our practice between different institutions and these are benchmarked against, in this case, quality indicators, but we do it for a whole range of different measures. So we're feeding back to the clinicians what they do. Similarly, we can look at the recommendations in relation to the control of mean arterial blood pressure. The recommendation talks about having a mean arterial pressure between 80 and 50 and what we should do to ensure that that's occurring. With our current data management systems, we can measure at 20-second intervals, or we can it's continuously displaying for us what our pressures and flows and all the other parameters that we measure are likely to be. So we need to use that data. We need to harness it. One way we can do that is by developing decision support systems, and there are some now commercially available decision support systems out there. This is one that we've been working to develop ourselves, whereby here we can have an action that prompts up as a suggestion. Your pressure is low, your DO2 is a bit low, your cardiac index is 1.8, do you want to increase your pump flow? Or it might get a bit more specific, your pressure's down to 40, increase your mean arterial pressure, give a vasopressor or increase your flow. Prompts that can help us deliver better care to our patients. Another way that we, use data to look at this aspect, and this is more about, looking at variation. This is our perfusion quality indicator report, which the perfusionist gets at the end of each case. The surgeon also receives an electronic copy of this. And there are a variety of different parameters reported, but some of them relate to arterial flow and pressure and definitions of variation that we've created as a clinical team. There's also a more detailed array of measures within our CPR local data interface that we can go back and look at. If we're at a M&M meeting and there's a question relating to hyperperfusion, we can go and we can check what actually happened for that patient. It's not, this is what I think happened. We actually measure it and we can talk about it. Another thing we can do is, and I've talked about it, is comparing ourselves to other organisations. Here we have a number of factors that we report as a community, and then we can see how we compare, how our practices compare to other institutions. And then we can ask the question, well, what are they doing? What are their outcomes looking like? Should we be changing our practice? So if we look at the modern perfusionist, the title that I was given for this presentation, what does the modern perfusionist look like in relation to data and registries? Well, I think they need to be open to understanding their practice. They want to learn every day. They need to strive to understand what is appropriate practice and what is clinical variation. They need to look for ways to link what we do in the operating room to our patients' outcomes, and that's incredibly important. We need to continually observe, measure, challenge, change and improve the art of perfusion. I'd like to once again thank the organisers for the opportunity for presenting to you today.
Thank you very much, Rob. It's so nice to see all of you live. Rob, it must be in the middle of the night now in Australia. 1 o'clock in the morning, I think. Thank you for your very nice presentation.
Yeah, it's about that.
I hope it came across well because there's some delay. I hope it came across well because the sound was a little bit loud, but I managed to augment my volume, so the message came across. Thank you. So I'm the moderating, looking at all the questions coming in. There are quite some questions, and we have about 12 to 15 minutes. So I suggest I'll give you each one question to start with. Dr. Boucher, one of the questions we got here is that when you see that your patient has a hypertrophic heart, when you see it in the operating room, do you discuss it with your perfusionist and do you adapt your cardioplegia protocol? Like increasing perfusion pressure, cardioplegia time?
That's a good question. We discuss it, indeed. We discuss it with the perfusionists. from our standpoint, from the cardiac anesthesiologist standpoint, we discuss it with the focus on perfusion, especially during weaning. Keep the blood pressure high enough, fill the patient enough during weaning. Regarding the cardioplegia, this is mostly addressed with the surgeon. The perfusionist and the surgeon will discuss how much cardioplegia they will give, and they plan this before the onset of surgery.
Okay, thank you. So how much is what's the level of involvement of your perfusionist with regards to TE? Are they really involved? Can they see the screen at all times? Can they discuss it with you? Are you allowing them in?
Yes, we not in the regular cases, in the normal cabbage patients, but if there is a problem, we discuss it before pump with the perfusion. They are not able to see it on the screen during CPB, but they are able to see and watch the screen from their seat, but we mainly discuss it before the pump. Yes, or if there is a problem during pump, I will notify them. Also, when there is a problem, for example, high pressures, arterial line pressures, we will discuss whether there is, for example, an aortic dissection, etc. We will keep in touch together and discuss if there is a problem. Yes.
Okay, thank you. I got some questions for the others also, but quite some questions concerning the brain in the non-normothermic regional perfusion. Caroline, how is the non-perfusion of the brain assessed? Is it via EEG or NIRS, or how do we do it? Because I think it's a very important one, no?
Yes, of course. So we use the NIRS system to monitor the brain, but as you all know, it's not a measurement that is really known for this situation. So we're also learning with using the NIRS. And if we see some change in NIRS, we look into our system, what we can do. And sometimes you also use Doppler to see if there is some flow to the brain. But what I also would like to say, if there is some flow, that doesn't mean that there is perfusion of the brain. And if there is perfusion of the brain, it doesn't mean that there is really some cellular restoration. So it's really difficult. But the main importance is that you try to drain the blood that is going to the brain.
Yeah, I think it's a very important one because there's a lot of ethical concerns around the procedure. One question also was about the correlation. There was a correlation between the time of the cold storage and the cardiac index. The longer the cold storage, the lower the cardiac index. Could you comment on this?
Well, yeah, of course. Well, it's also something that we still have to look at because we try to limit the cold ischemia time because most research that is done is by combining the NRP technique with ex vivo heart perfusion. We have decided to not do this, but to go to cold storage, and therefore we really try to keep our cold ischemia times as short as possible. We don't know how long we can keep it, so it's still something that we need to sort out.
Yeah, there's somebody who says that how do you determine the length of the NRP time? Because in their center, their donor was only perfused for 6 minutes and another one for 108 minutes.
Yeah, so every donor is different. And also, this in the first two heart transplant that we did, the donor was located in another hospital, so we also had to follow the protocol of that center. So that was a fast weaning of the NRP. Most of the time, the experience that we have is longer times of NRP. just to control everything, to make sure that before we wean from NRP, everything is stable. So that takes at least 30 minutes and sometimes even more.
Okay, thank you. Rob, now you're awake. We will ask you a question as well. The question here that came in that I see here is, how can we overcome the barriers that hold perfusionists back from being more involved in data collection and usage for quality improvement?
Okay. Well, thanks very much, Celine, for this opportunity, and I'd just like to thank the other two speakers for two very interesting presentations. Look, you know, sometimes we're our own worst enemy. I think that the perfusionist needs to just show the rest of the team that they're an important component and an integral component of that team, and that they've got the ability to utilise the data that is available. I think sometimes where perfusion is not recognised is that people don't see a direct relationship between what we do and clinical outcomes. And I think as we go forward along this journey of being able to integrate more electronic data and more real-time data, we're going to be able to demonstrate even stronger relationships between what we do in the operating room and the clinical outcomes. And I guess the low-hanging fruit there to a degree is relating some of the activities we do and acute kidney injury. And we've seen that already by being able to look at some of the DO2 data and kidney injury, or some of the temperature data in kidney injury. And I think there's, you know, a lot of relationships between different data sets that we just haven't been able to tap into previously, but with the processing power that's, you know, becoming more and more every day, I think we're going to see an explosion of understanding of what we do clinically.
Thank you. In the meantime, I'm looking at my screen. If I'm not always nodding, it's because I have to multitask here, but I'm sure the audience is nodding massively. One more question, Rob, is can you explain how you technically limit non-bypass time influencing the key performance index data on Connect?
Could you just repeat that? Sorry.
I will read the question as it comes in. If you can you explain how you technically limit non-bypass time influencing the key performance index data on Connect? Connect is the computer of the LivaNova.
Yep, the LivaNova data management system. I think that's a fairly detailed technical question, but the bottom line is that by correctly using the bypass on, bypass off start keys, you should be able to limit the quality indicators to just the period of bypass. Depending on how you process that data, you can look at a variety of different periods. We can separate it off to separate out, for example, the period at the end of the case when you're weaning from bypass, because you're obviously going to go through a period there where, you know, your flows are going to be quite outside of your quality indicator range. However, that's because you're doing that transition from bypass support to the patient's own heart. So it's a matter of understanding the data and being able to put into your data stream some flags, if you will, that allow you to look at different sections of the bypass to properly look at your quality indicators.
Thank you. I'm sure if it's not clear enough, it's for me perfectly clear. but if not, people can ask more questions. One more for Carleen. I think it's an important one. How is this affecting your workload, and did you need to hire more people for this?
Well, no, we haven't hired extra people for it, but it's really asking a lot of your perfusion team, because it's not only the NRP, but after the NRP, you have a whole transplant program that you have to run also. So if we have a complete TA NRP donor and all the organs stay in our center, you need at least 5 perfusionists to run this. So it's a huge work, and you need a really good team to make this happen. So it's asking a lot of us, yeah, but it's worth.
But I'm sure you have a good team over there in Leuven.
Yeah, of course.
Good. I think I can ask Rob one more question, because as long nobody's whispering in my ear that I have to stop asking questions, I'll continue. Rob, one question, I think it comes from Carol. Can you comment on data management collection and data management usage in the way of research projects such as clinical outcomes?
Okay. I mean, I think that's where our data systems are just going to provide such an enormous amount of opportunity. We've done a number of studies now where we've been able to harness the electronic data from the heart-lung machines to form the basis, if you will, for research projects and publications. In our ANZ CPR collaboration, we actually collect the 20-second data from all of the units that contribute for all of their cases. So you can imagine that that's got an enormous amount of data in it, that registry. And then we can process that data to give us the answers for questions, but no longer from just one centre, but from many centres. And that really unleashes an understanding that we haven't been able to have before. And our collaborations, DO2 work and work on hypothermia are 2 examples where we can use that enormous data source to provide some supporting evidence for some of the things that might come out from randomised trials or other trials. So the registry data is an incredibly valuable source that we can use now.
Yeah, thank you. Dr. Boucher, people are wondering, do you teach perfusionists during TE in the clinical setting or only in a theoretical fashion?
Well, I teach the future perfusionists in Belgium, in the perfusionist school. And then during clinical practice, I often show them things and explain them things, why it's important for the perfusionist. Yes, I do that.
Yes, I know you're teaching in our perfusion school, but that's mainly theoretical. Huh?
Yes.
It might be interesting to incorporate a little bit of practical part also, no?
Yeah, absolutely.
But I know from your teachings you incorporate a lot of videos and so it's really quite realistic. So that's a good thing. I think we need to move on. I would like to thank all speakers for their pre-recorded presentations with excellent talks, and also for being with us here live, answering questions. And I now would like to move on with the second part of our scientific session. And this part consists of abstracts which were sent in by colleague perfusionists from within Europe. And we selected a few of them. due to time restrictions, we could only select 4, and the other accepted abstracts you can see and read in our booth. The first abstract that we thought was interesting and which we accepted is the one from the group of Gudrun Kunst. It will be presented by a science student, Livia Kotel, and it's about anesthetic and perfusion practices in adult cardiac surgery, a multi-center international survey on cardiopulmonary bypass.
So my name is Livia Gautel. I am an undergraduate science student at Edinburgh University, and I will be presenting today our study titled Multi-Center International Survey on Anesthesia Practices in Adult Cardiac Surgery with Cardiopulmonary Bypass. I would like to start with a special thanks to the organisers for inviting me to give this presentation, and I would also like to, of course, thank all the other co-authors of this paper, particularly Dr. Mohammed Akhtar, who conducted the survey in collaboration with EACTA under the leadership of Professor Gudrun Kunst from King's College Hospital in London. And there are no conflicts of interest. So we've conducted a survey to essentially assess current anaesthetic and perfusion practices in adult cardiac surgery during cardiopulmonary bypass across European and non-European countries. Within the different anaesthetic and perfusion practices, the following variables were surveyed: hemodynamic and tissue oxygenation parameters, organ protection measures, and lastly, monitoring and usage of anaesthetic drugs. So in terms of the questionnaire itself, we used SurveyMonkey to reach out to as many cardiac centres as possible via an EACTA mailing list. We made use of its simple interface and easy accessibility to create 28 multiple choice questions distributed via email, and it took about 10 minutes to complete. In order to reflect clinical practice realistically, it was possible to take more than one answer in a small number of questions. And lastly, all results of the survey are presented descriptively, so no formal statistical analysis was necessary. And this is just a quick example of how the question and answer choices were phrased. So this is just a snapshot of questions 7 to 10. And here are a few results from the responses we received. In total, 797 centres were contacted. The response rate was 34%, and we also removed duplicates and incomplete responses, bringing the grand total to 202 responses. Overall data from 56 countries was received, and 60% of the responses were from European countries, and more than half of all centres performed more than 500 cardiac cases a year. So I'm going to talk you through a selected choice of results from the questionnaire itself. So within hemodynamics and oxygen delivery, optimization of pump flows and tissue oxygenation parameters were applied by the majority of centres, with target flow rates above 2.2 litres per minute per square metre of body surface area. Targeted mean arterial blood pressures, or MAPs, were between 51 and 90 millimetres of mercury in 85% of respondents. A third of centres used individual mean arterial pressures for different patients, and the other category here included, for instance, employing a high flow or low pressure principle. So there was a bit of a split in the results when we asked about blood transfusion triggers, with the majority of the centres choosing the lowest haemoglobin, between 7 and 8 grams per decilitre in 59% of centres, but also 1/3 used individual triggers for different patients. The other answers specified using 6 grams per decilitre or using other triggers such as decreased central venous oxygen saturations. Mixed venous oxyhemoglobin saturations were routinely assessed in 59% of centres and lactate in 88%. So in terms of monitoring during CPB, the preferred site for temperature measurements was the nasopharynx. The other category here included mostly blood or pulmonary artery temperature, or also the skin. You can see that the minimum urine output during cardiopulmonary bypass triggering treatment was variable, ranging from 0.5 and up to 2 milliliter per kilogram body weight per hour. 30% of centres used individual minimal urine output triggers for different patients. With regards to CPB-related anaesthetic techniques and medications, anaesthetic techniques were very spread across the answer options in terms of management of lungs, including apneic oxygenation, low tidal volume ventilation, continuous positive airway pressure, and disconnection of the endotracheal tube from the ventilator. Other answers highlighted unlisted techniques and mostly switching the ventilator off. So everyone is probably aware of the recently published European Multidisciplinary CPB guidelines in adult cardiac surgery. And in accordance with these guidelines, lower MAPs as well as higher MAPs were chosen during CPB in the survey, with the majority of centres using MAPs between 51 and 90 millimetres of mercury. In the survey, oxygen delivery during CPB was only monitored regularly in 38% of centres. However, the components of oxygen delivery, i.e. hemoglobin levels and pump flow rates, were optimised in the majority of centres. Central venous hemoglobin saturations and lactate were also assessed in the majority of them. And is there an ideal urine output trigger during anaesthesia? Well, this survey showed that only 6% of centres considered 1.1 milliliter per kilogram body weight per hour or more as the minimum urine output to trigger treatment. Most centres used individual urine output or less than 1 millimeter per kilogram body weight per hour as a minimum output to trigger treatment. So the main limitation with our survey was the length limit, as it forced us to narrow down the range of topics and disregard other themes that would have otherwise been of interest to us, which included teamwork, details of CPB disposables, and anticoagulation management, as well as others. The other limitations mostly lied within the variety of responses. For instance, the survey didn't include non-EACTA members, perfusionists, or paediatric anaesthetist. Overall, this survey revealed to us that techniques for optimization of pump flow and oxygenation during CPB were usually applied. However, most CPB-related anaesthetic techniques were more variable. To our best knowledge, this is the first international survey of its kind to be conducted, and our results can be benchmarked against some of the recommendations from the 2019 Interdisciplinary European CPB guidelines. In the future, however, more high quality randomized control trials would be needed to assess the anaesthetic techniques. And thank you so much for your attention and for listening.
Thank you, Olivia. It was very interesting. I'm sure we will hear more about it. I hope we will hear more about it. I'll see you in a few minutes live, but first we go to the next speaker. We'll have all the speakers first and then the questions and answers afterwards, like the previous part we did. I'm very happy to introduce now Frank Merkel. I'm very happy because it's a topic that's really close to my chest about simulation. His abstract he sent was the simulation-based training of critical events during cardiopulmonary bypass.
Hello, my name is Frank Merkel and I work in Berlin, Germany as Perfusionist instructor. And we were doing a study on the evaluation of simulation training for perfusionists and the importance of a critical events checklist. I have no disclosures regarding this presentation. And this study we did was recently published in Perfusion. The idea is that if you have low PO2 on bypass, you would have to make a decision whether or not you would like to change out the oxygenator or if it's a problem of the gas supply. So in this case, if they have a low PO2 on bypass, you can draw venous blood gas, you can then hook up oxygen supply, to the oxygenator, bypassing the wall oxygen supply. And then he can measure another arterial blood gas and then see if the PO2 goes up. So this is proof that the gas supply from the wall or the oxygenator or wherever, so the oxygenator connection is not working. If the PO2 stays low, it can either be the oxygenator itself or the patient, and you can discriminate between the two, having a look at the venous blood gas, and then you can see if there's an oxygenator failure or if it's a problem with the patient. We were using our simulation lab to detect whether this checklist would actually work. So we invited 19 perfusionists from our hospital for the first scenario, and we split these up into two groups. Group A was the one that after the first scenario received the checklist for debriefing, and Group B did not receive the checklist. When we repeated the experiment some weeks later with 14 perfusionists, and then we also added another incident to make it more difficult. But Group A uses the checklist during the scenario, and Group B did not have access to this checklist. Now, as you can see here from the timeline, there is an eye tracking recording time, and below at the bottom is the CPB time. And we had 5 different phases. First, phase 1 was before bypass, phase 2 was going on bypass, phase 3 cross clamp on, phase 4 detection time, and 5 was decision. And FiO2 was lowered just after cross clamping, and in the second round also additionally line pressure was increased by partially clamping the arterial line. We were using eye tracking, video surveillance, audio recording, heart rate measurements, nasal task index questionnaire, and also conducted semi-structured interviews. And this just gives you an idea what we did. So here is a snapshot or a picture of the hardline machine console during simulation. And you can see the colored areas are the areas of interest that we defined. We had 30 of these, and you can see how long and how often people are looking at these areas of interest. It was also then possible to look at the pupil diameter sizes, so it was interesting to see that. This is an overview of the simulation lab. You can see in the top 2 pictures is the camera, and on the top, on the bottom 2 is the simulated monitor, patient monitor on the left side, on the right hand side the blood gas monitor coming from the Orpheus. We had ECG taken and then extrapolated heart rate variability measurements from that. We also, next to that, asked the participants to fill out the nasal task index questionnaire after every scenario. And finally also, just in a second, hopefully, yeah, you can see that the results that you have the areas of interest according to the phases. On the left side, phase 1 before CPB, so there's a large area of interest, so the perfusionist is scanning the whole CPB console before going on bypass. Then phase 2 is going on bypass, it's the arterial pump, it's the patient monitoring is of course of more interest. Phase 3 cross clamp on, so it is the cardioplegia monitor, the arterial pump, and the line pressures. And then in phases 4 and 5, you can see phase 4 detection. So the blood gas, the simulator blood gas is of course of highest interest there, and it's almost exclusively looked at. And then phase 5 decision is where some attention is given to the oxygenator, but it's a more also widespread attention, because a decision has to be made and causes have to be identified. So very interesting, the results, the quality of decision. So we rated as correct if the perfusionist identified the gas supply as missing, and it's not the oxygenator failure. So in round 1, between groups A and B, there was not much different in whether they made the correct decision. But in round 2, where the group A had the checklist, 100% of those were identifying gas supply as the problem and were acting accordingly, whereas in group B, there was no difference to group A. We also had a look at other parameters, as already described. Reaction times, of course, times were shorter in the repetition of the experiment, And this was significant. Time to decision was much faster in the second round. However, there was a difference between groups A and B in the second round, because those of group A having the checklist were reacting even faster than those in group B. So we also had some more parameters tested. And we could see that between groups A and B in the second round, Group A had to use the checklist. Of course, temporal workload was high, whereas Group B did not have to use a checklist, and they had lower temporal workload experienced than Group A. Pupil diameters, not surprisingly, went up, going on bypass and also making the decision, telling us that if the pupil diameters go up, probably it's more attention, more stress. And heart rate also increased, especially in phase 5 when the decision was being made, but also in phase 4 when the detection was being made. And we had some more results coming from the heart rate variability measures. And there was a significant correlation between heart rate and stress index, one of the parameters for sympathetic activation, and pupil diameters and RMSSD, which is one of the parameters for parasympathetic activation, and also pupil diameters and stress index. There was no significant correlation between pupil diameters and heart rate. So I'd like to conclude that the use of a critical events checklist improves probability for correct decision making and shortens the time to decision. Temporal workload is increased when using the critical events checklist. Eye tracking and heart rate variability measures appear well suited to evaluate individual participant behaviors and stress levels, and all participants welcomed simulation training for incidents and would favor broader availability. Thank you very much.
Thank you very much, Frank. It's always very interesting. We'll see you live at the question and answering session later on. The next talk, we accepted an abstract from Rafael Pereira from Portugal, and an abstract about positive balance during aortic valve replacement. Can we protect the kidney?
Good afternoon. I am here to present my work about extracorporeal circulation with positive fluid balance during cardiac surgery. How much can we feel? My name is Rafael Pereira and I am a perfusionist at Hospital Santa Maria in Lisbon, Portugal. I would like to thank the organizing committee for the opportunity to present my work at this event. I would also like to congratulate the organizing committee for its versatility and capacity to adapt to the new reality we are living. I have no disclosures. Aortic valve replacement remains the gold standard treatment for low-risk patients with aortic valve disease. Cardiopulmonary bypass is a crucial tool in cardiac surgery and is associated with hemodilution caused partially by the priming or intravenous fluids administration. It is known that hemodilution increases capillary permeability during cardiopulmonary bypass, increasing the risk of tissue edema. Although there are many publications on this topic, the discussion of the fluid balance composition and amount to avoid or reduce postoperative organ dysfunction is still controversial. In this study, we aim to evaluate the effect of intraoperative fluid balance and diuresis on postoperative outcomes and survival. Here I show you the method of our work. We have included 265 patients submitted to non-emergent aortic valve replacement from January 2016 to January 2018. All patients had the fluid balance calculated considering the differences between fluid administration, such as intraoperative intravenous fluids, priming, and the crystalloid part of cardioplegia, and elimination, such as diuresis and residual priming. After fluid balance calculation, patients were divided into 3 groups. Group 1, with patients with negative fluid balance, with 38 patients. Group 2, with positive fluid balance less than or equal to 1,500 millimeters, with 185 patients. And finally, the group 3 with positive fluid balance greater than 1,500 millimeters with 42 patients. Primary endpoint was postoperative outcomes such as diuresis, ventilation time, hemodynamic support, blood transfusion, and acute kidney injury. And secondary endpoint was survival. As you see in this table, no differences between groups were observed, with special attention to a similar distribution in chronic kidney disease, Euro score, or even left ventricle function. The results of our studies suggest that patients with positive fluid balance were associated with a significant increase in diuresis during surgery, as you can see in the left side. Furthermore, these patients had lower creatinine levels at 24 hours post-operative. These results were statistically significant between the positive and negative fluid balance groups, as you can see in the right graph. In our sample, the risk of acute kidney injury was higher in the group of patients with negative fluid balance, with an odds ratio of 1.6 when compared with group 2, or 2.2 when compared with group 3. Patients with positive fluid balance had lower ventilation times when compared with patients who had negative fluid balance, as you can see in the right side. For the remaining variables under study, no significant results were observed. Considering the secondary outcome of our study, patients with negative fluid balance had worse survival at 40 months than those with positive fluid balance. Finally, to concluding, our work shows that negative fluid balance is associated with less diuresis and higher postoperative creatinine levels, with higher rates of postoperative acute kidney injury. These results suggest that fluid balance above 1,500 millimeters confers better renal protection during cardiac surgery with cardiopulmonary bypass. Furthermore, no significant results were found for the remaining outcomes, which may suggest that negative fluid balance may be more harmful to the kidney than other organs. In addition, and answering the question that gives title to this work, weaning from cardiopulmonary bypass with as few as possible patients showed better results to prevent acute kidney injury and improve survival. Thank you very much for your attention. This is my email address. Please do not hesitate to expose any doubt or question.
Thank you, Rafael, for your very nice scientific contribution. I'm sure there'll be some questions coming, and I look forward to seeing you in live at the end of this session after the next talk. We have one more abstract to listen to. The next abstract comes from Ignacio Condeno from Italy, and he has sent an abstract about the C-reactive protein in water leakage from gas exhaust of polypropylene oxygenators.
Hi, good afternoon, everyone. It's a great pleasure for me to present this study that we do at our institution from Antea Hospital, Gruppo Villa Maria in Bari. The title of this presentation is C-reactive protein in water leakage from gas exhaust of polypropylene oxygenators. We now report conflict of interest for this study and presentation. Condensation and water loss from gas output of the cardiopulmonary bypass oxygenator has been the study object of several research. At our institution, we carried out different studies on condensation for polypropylene fibers oxygenators. Literature just already explained the water leakage phenomenon in the oxygenator with polymeric materials for the heat exchange membrane. We observed during the circulation of water in the heat exchange the production of steam and water leakage in the inlet oxygenator. This depends on the nature of polymeric materials. However, for polypropylene of oxygenator fibers, little is known about the propagation of the condensation formed at the level of oxygenator and how potentially it contaminates the surrounding environment. Our journal of cardiac surgery, we present the document that show the moment of formation of gas steam from gas outlet of oxygenator during cardiac surgery procedure. We using thermographic camera for capture the condensation phenomenon around the oxygenator perimeter with the same color temperature called similar of gas outlet. In this document, we present the use of the aspiration at the level of gas outlet of oxygenator that also favor the elimination of condensation and improve gas exchange and potentially reduce the absorbed substances in the operating room. Creation of water condensation in blood oxygenators is a phenomenon that is constantly present during cardiopulmonary bypass and in medium to long-term extracorporeal life supports. The clinical observation of condensation at the oxygenator exit is still a common event, normally associated with sudden cooling of the gas flow proximal to the outlet cover, where the warming effect of blood is no longer present. Because of the microporous nature of the membrane, blood plasma can evaporate at the liquid membrane interface and diffuse as water vaporizes through the pores into the intraluminal gas phase. We published in this context an article about 48 oxygenator about the correlation between water condensation and gas exchange during cardiopulmonary bypass in different models and fibers of blood oxygenators. We applied different methods, for example, normothermia with and without suction of the gas outlet of oxygenator, and mild hypothermia with and without aspiration of gas outlet of oxygenator. This is the system for the connection, the vacuum tank for the quantification of water leakage in the gas outlet of oxygenator. Each model of oxygenator presents different volume of water leakage production that depends of temperature management and the application of vacuum during the procedure. This study is showing an inversely proportional correlation between gas exchange and condensation in statistically significant values. In polypropylene and polymethylpentane fiber oxygenators, the production of condensation was increased at the oxygenator gas outlet during the use of normothermia. Limiting the use of the heat exchanger time during cardiopulmonary bypass will seem to reduce the production of water loss and condensation, and improve the stability of the exchange, in particular of the oxygenation, in the long-term extracorporeal circulation. The aspiration used in the gas outlet could favor the elimination of condensation, particularly in the polymethylpentane oxygenators, and the favor gas exchange. However, further studies are needed to validate these preliminary results. During SARS-CoV-2 pandemic, each professional asked himself if SARS-CoV-2 does not spread through extracorporeal membrane oxygenation or dialysis membranes. The study showing that RNA of SARS-CoV-2 was not detected in the membrane oxygenator gas outlet condensation in the first 40 hours of use of ECMO and in dialysis effluents. However, the study we don't explain the methods for the collection of the steam during the procedure, in particular for evacuation of oxygenator. This context for the absence of the study on the spread and contamination of the polypropylene fiber of oxygenator, we do a study in patients COVID-free. 20 blood and water loss samples were collected at the Antia hospital for the polypropylene fiber oxygenating models after 120 minutes of extracorporeal circulation during cardiac surgery procedures. For samples were used a sterile tube connected from gas outlet to a sterile container subjected to control with negative pressure less 8-10 millimeters of mercurius. Approximately 6 milliliters of condensation was collected in each oxygenator, which were subjected to quantitative spectrophotometric determination of C-reactive protein. C-reactive protein is a well-recognized marker and a possible mediator of systemic inflammation. Low concentration report 1 milligram liters and moderate concentration report 3 milligram liters and high concentration report 3 milligram liters. C-reactive protein risk categories are currently used to predict cardiovascular events in a surgical population. In this context, presented the patients that reported 1 milligram liters of C-reactive protein during cardiopulmonary bypass for serum value. C-reactive protein is an annular pentameric protein found in blood plasma, whose circulating concentration rise in response to inflammation. In the human body, amyloids have been linked to development of various diseases. About 10% of amyloid deposits are made up of C-reactive protein with 7 and 13 nanometer in diameter, normally found in the blood, which increases in inflammatory states. The results of the study show that the 20 condensate samples analyzed for quantitative spectrophotometric determination of C-reactive protein report 0.15 milligram liters in water leakage, the 15% of serum value. These measured values show indirectly a possible smaller pathogen passage with condensation through polypropylene oxygenator fiber. However, further study and investigations are needed to confirm these preliminary results. Thank you so much for your attention.
Thank you, Ignacio, and welcome all of you. It's nice to see you in real. We are missing Rafael. He apologized just last minute, but that's no problem. There are more questions for the three of you to answer. I will just read the questions at my other screen. I'm not asking questions of myself because there are plenty of questions coming in. So my first question, Livia, hello. Says,
hello.
Congratulations for your survey, and I can only back up this one. The question was, do you have any data about the kind of CPB and especially how high was the proportion of mini bypass systems?
Yeah, so that would be an excellent question for future surveys. We didn't actually ask about ME-EC techniques in this survey, but we would definitely look into it for any future ones.
Okay, and a question, well, I got this a few times, so people want to know, does the anesthesiologist stays in the room in your in the UK during CPB?
Yes, so in the UK, the anesthesiologists do stay in the room. I mean, we didn't ask this in the survey, but they can leave in the theatre, but they need to be contactable, and they can also stay in.
Okay, I have some more questions, but I want to divide them a little bit. Frank, a question for you. It's always interesting, this eye tracking system. And somebody was wondering if you can use it to train behavior in the operating room, such as paying more attention to the table activity versus that of the surrounding noise.
Yes, certainly. You know, we did 4 studies all in all. So the first one was we called it a pilot study, where we used it in a hospital setting, and we were recording several cases, and we were finding that the behaviors of those that are experts are actually different from those that are newbies on the job. So, of course, it was an idea to use eye tracking as an evaluation tool for training. The problem is it's not a live view. So, I mean, in order to evaluate that, you'd have to record the data and evaluate it, and it takes some time. And then it's not a good feedback thing either. So I don't think it's a tool to train, but what you can do is you can try to evaluate or assess people's behavior. So after the training you did, maybe in the simulator or maybe on the real operating room, you then can go back after some time and see whether there has been any change. And I think this would make more sense.
Yeah, and you're talking about this simulation-based training. Do you consider to use this approach also with your colleagues, people who are already experienced perfusionists, or don't you think there is a place to put people behind a heart-lung machine and retrain them on a regular basis? Or
that study This study I just presented, these were all experienced perfusionists, not students. So these were actually clinical perfusionists from our hospital. And yes, they even stated themselves that it would be perfect that if we had more scenarios at a regular interval, like to be trained in certain scenarios where catastrophic things, which don't happen very often in the hospital.
Yeah, and it's a thing. It's time and resources. Huh? I hear a lot of feedback from perfusionists and students that they would like to have more simulation into their daily practice. But if it's not compulsory, it might not find much. You might not have the resources or time to do it. I think it's quite important, and maybe it's something that EBCP could have a look at it and implement it or force it on the recertification to have some simulation trained or retraining. What do you think?
Well, you know, I'm already providing these courses for international perfusionists here in Berlin, and I can say that it's quite effective. And yes, why not? I think it would be a good idea to collect points through active participation in such a simulation session. And we can set it up if you want. So it's possible, but it will only be possible after the COVID crisis because we can't accept external visitors at the moment.
Yeah. Now you're mentioning the COVID. Are you continuing with your to do the simulation with your own staff, with the hospital staff, or that's also finished? That's
yes.
also finished. Yeah. Okay. Yeah, it's a burden, huh? Ignacio, I also have a question for you here coming in. Does that mean that COVID-19 can actually be transferred to the air during CPB and ECMO?
I think that the membrane between ECMO and CPB is a difference. I think that we have major risk during cardiopulmonary bypass, but we don't have in this moment scrubs for COVID-19 during CPB procedures.
Mm.
Okay.
And somebody was wondering, how did you get the idea of measuring CRP?
C-reactive protein. The advantages of C-reactive protein is that the nanometer and the diameter of serotonin protein is similar to the diameter of coronavirus. And for a similitude is a good benchmark for evaluation for the contamination of steam. However, further study are needed to evaluate this statement.
Okay. Good. More questions for Livia in the meantime. Seems that medication is one of the bigger issues. What medications are you allowed to give during CPB as a perfusionist?
Yeah, so in the UK, perfusionists give vasoconstrictors during CPB, and we actually asked this in the survey, and the answers that we got was that the majority of centres within the UK give norepinephrine, and that was 72% of centres give that drug. Yeah.
Okay. And then another question is, do you take into account the amount of volume the anesthetist gives pre-CPB, as this would have an effect on total volume and hence cardiac output?
Yeah. Yeah, so that's really important to take into account the amount of volume given pre-CPB, and so of course the anaesthetist does take this into account. However, we didn't ask this in the survey. This would be another point to maybe raise in future surveys.
Okay, Ignacio, there's somebody who says that CRP augments only after a few hours post-CPB. So he was wondering, or she, I don't know, what's the clinical value of measuring it during CPB?
Of serotonin protein?
Yes.
During CPB, we measured in serum low value of serotonin protein, approximately 1.0. And the value that we found in the condensation in water leakage is 0.15, 0.12. The 15% of concentration of serum value is a low concentration, very low concentration, but we observe a presence in the water leakage of the trace of serotonin protein.
Okay. Livia, one of our colleagues here was wondering how accurate do you think this type of survey data is compared to real-time data?
Yeah, of course. So, I mean, this survey was a snapshot of different centres. So real-time data would be more accurate because it is more comprehensive, but real-time data would also need to be analysed appropriately, which requires a lot of resources.
Okay. Is any one of you having questions for the other ones? I wanted to do that in the first group also, but I didn't have time. But now if you would like to ask a question to one of your colleagues under or next to you or above you, please. Frank, do you have a comment?
Yes, I have a comment or a question for Ignacio, because I think the study you did, this is very good, and I hadn't even thought about it, to see whether there are vapors coming out of the oxygenator exhaust, and especially, as you have pointed out, in COVID patients on ICU. And this is clearly something that I think nobody has thought about before. And if this is true, this means that we have to find the solution for that problem and maybe filter that exhaust or whatever, or make sure it doesn't contaminate the air. So this is fantastic idea to measure that. Thank you very much. I'd just like to thank you on this.
Thank you, Frank. Thank you. Thank you.
Ignacio, you have a question? You like to ask?
Is very interesting the simulation of your center and the evaluation of the diameters, of the pupils, of the heart rate. You think that a good perfusionist have physiologic characteristics?
Well, that is actually a very good question. One of the ideas was if we could, because this has been described in airline pilots, right? So if it's possible to see if somebody has more experience, and if they have more experience, they will stay calm and not have a big increase in pupil size or heart rate. Now, actually, it's not as simple as that, because I found that some experienced perfusionists had very high variations. And it seems to be more a question of personality or like the mental state of that person, and not so much of professional experience or length of practice. So, and one of the reasons we see that is that, airline pilots are usually very selected persons. So they are usually a very good physical and mental health, and they go through a process of evaluation, of assessment before they can even fly an airplane. Now in perfusion, this is not the case. So you have to be, of course, somewhat mentally and physically fit, but we don't have this psychological testing before we are taking up the profession. And this means that you have all kinds of people on the job. And so I found huge variation, and this could not be explained by the number of years experience or by the sex, like the women and men. So there was not any difference really, or no significant outcome from that. So, but this is very interesting. So I try to take this further and see whether we can have a look at it again and see what is actually determining how you react.
Very good.
Thank you, Frank. Sorry to interrupt you. We need to close off, but I want to give Livia the opportunity. If you have a comment or a question that you would like to ask, because we didn't get the opportunity online.
No questions.
Okay.
But I wanted to thank everyone else for the presentations. They were really interesting. Thank you.
Well, that's it then. Thank you, all of you, for your contribution. Sorry for the technical problems we had. This is a new era. We all are struggling through these technical approaches of these meetings these days. But I think it went very well. So that's the end of it. I hope we see each other next year live again. And maybe we can meet at the bar afterwards for a virtual mojito. Have a nice evening, and thank you again.
Thank you, Urine. Bye.
Bye.
Thank you.
Bye. Thank you, everybody.
Bye.